Hi everyone, today I'm going to be discussing Chapter 23, the reproductive system. So here our goal is to discuss sexual reproduction, take a look at both male and female reproductive systems and their associated disorders, and then we'll finish up with a discussion regarding sexually transmitted diseases. If you're curious to know what the vagina and tomatoes have in common, or if size really does matter, stay tuned. Until the late 17th century and early 18th century, physicians believed in a one-sex reproductive model of thinking. This means that physicians believed that the sexual organs of the female mirrored those of the male. Now, they noticed some differences, but they suspected that internally things were pretty much the same. Well, today we know that that's not true, and we understand that human sexual reproduction involves two parents, which is referred to as asexual reproduction. This is significant because when gametes divide, the genetic material inside has a way of randomly reshuffling itself or recombinating. So what this does is it increases the variation of the genetic traits among offspring of the same parents. That's why you look similar to your brother and sister or your mother and father, but you don't look identically the same in most cases. Now, some terminology that we need to familiarize ourselves first before we continue on. The first one is gamete. And a gamete refers to a sex cell. It's a generic term that refers to either the male sex cell, which is the sperm, or the female sex cell, which is the ovum. Now, when the male sperm and the female ovum fuse during fertilization, this creates a one-celled zygote. This is the first cell of the offspring, and we're going to see as we dig a little bit deeper into this lecture that cell will begin to divide very quickly, and then it is referred to as something called the blastocyst. So we'll get there in a second. Again, the sperm is the gamete from the male parent, and the ovum is the gamete from the female parent. I think it is fair to say that any organism on our planet has the goal of reproduction, and the human species is no different. So where does that urge to reproduce come from? Well, in the human species, it comes from hormones, and these hormones initiate something called puberty. And at the beginning of puberty, certain hormones are going to be ramping up in the male body, like testosterone, and in the female body, estrogen, progesterone, luteinizing hormone, follicle stimulating hormone. All of these hormones are going to initiate changes in the body and get us ready for that reproductive cycle. Each system, whether it's male or female reproductive system, is uniquely adapted for its purpose. Females are born with all of their gametes. So they are born with their ovaries full of eggs, and they never make any more for their whole life, all right? What this means is that the ova of the female are going to age with the female. Males, on the other hand, are continuously producing sperm and will produce sperm probably throughout their entire life. The male reproductive system is defined by its essential organs and its accessory organs. The essential organs are the testes or the gonads, and these organs are responsible for producing those sperm and also for producing testosterone. The accessory organs of reproduction are the ducts that carry the sperm and semen from the testes to the outside world, and the sex glands that produce semen, and lastly, the external genitalia. And in the urinary chapter, we talked about how the male urethra has a dual function. It functions both as a pathway to carry urine and as a pathway to carry semen. So we're going to look at each of these organs in detail. Here we can see an overview of the organization of the male reproductive system. And down here at the very bottom, we talked about essential organs, and those essential organs are the testes. They're shown right there. And then everything else is considered accessory organs. A couple that I would like to point out, the prostate here is going to contribute to seminal fluid, as well as a couple small glands that are located near the prostate called the Cowper's glands or Bulbourethral glands. And then we have a significant amount of duct work, if you will. And so we have that urethra that passes through the prostate and into the penis, so that's going to carry both urine and semen. We also have the vas deferens. The vas deferens is going to be the pathway where sperm leave the epididymis, where they kind of grow up and mature, and they're going to be able to leave the testicle via the vas deferens and enter into that pathway. There are also ejaculatory ducts that are there, as well as the seminal vesicles, all working together to perform one purpose, which is to make sure that the semen have this rich, nourishing fluid that will protect them on their journey. Okay. Suffice it to say that sperm are very finicky about the temperature of the environment that they live in and they grow up and mature in. And for them to have the best chance possible, the testes are held in the scrotum, and there are a couple muscles in there, the dartos muscle as well as the cremaster muscle, and those muscles are responsible for raising and lowering the testicles so as to regulate the temperature so that it is a welcoming environment for the sperm to grow and mature and survive. The testicle is what we're looking at here with the scrotum removed, and you can see that it is filled with these convoluted tubes. And in the testicle, these convoluted tubes are referred to as the seminiferous tubules. Now, this is where the sperm are born, if you will. Once the sperm are born and developed, they are going to start a long journey to the epididymis. So all of those seminiferous tubules kind of culminate in this one specific area and then lead the sperm towards the epididymis, and in the epididymis is when where they're going to mature, okay, until it's time for reproduction. Now there are these special cells, these interstitial cells that are in the testicles, and these cells are responsible for producing that hormone that we mentioned earlier, testosterone. Here we get a microscopic look of what testicular tissue looks like, and you can see that they've identified these interstitial cells, right? These cells that are going to be responsible for producing that testosterone. And then this big thing right here, there's several of them, right? But this is a cross section of that seminiferous tubule, and you see these little dots or sperms that are at their different stages of development, and then they migrate towards the center of this seminiferous tubule, and then that's how they journey through the testicle and then eventually end up in the epididymis. The main function of the testes is to perform something called spermatogenesis, and this means the making of those sperm cells. All right, so I created this chart to hopefully kind of simplify the steps for you. Now, during the development of the male fetus, stem cells differentiate into spermatogonia, right? And they're just going to be multiplying and copying themselves via mitosis. Remember, mitosis results in 2 identical daughter cells when there's a division. So at this point, when the fetus is developing, this is what's happening as the male grows prior to puberty, okay? Now at the onset of puberty, something happens. The hypothalamus starts this whole process in motion by releasing something called gonadotropin releasing hormone, or GnRH. And this hormone is going to send a chemical communication to the posterior portion of the pituitary, and it's going to tell it to release 2 other hormones, or gonadotropins. And these are exactly the same for male and female, so you'll hear them again when we talk about the female reproductive system. But these gonadotropins are follicle stimulating hormone and luteinizing hormone. We abbreviate those as FSH and LH respectively. So now these gonadotropins are going to be floating around in the blood, and they are going to stimulate the gonads. In this specific instance, it's going to be the testicles. So they're going to stimulate the testicles, and those spermatogonia are going to divide once again. Now, remember that microscopic image that we looked at of the cross section of the testicular tissue, and we saw those seminiferous tubules. Well, these spermatogonia live on the periphery of those seminiferous tubules, and as they divide, they're going to migrate towards the center. Okay, so that's what's happening here. So the spermatogonia are in the periphery. These 2 gonadotropins, FSH and LH, have stimulated those spermatogonia to divide once again via mitosis, but this time, instead of resulting in 2 identical daughter cells, one is going to remain a spermatogonia and the other one is going to go on to become something bigger and better, the primary spermatocyte. Now, the spermatocyte is going to divide again, but this time it's going to be different. This time the spermatocyte is going to divide by meiosis. Remember, meiosis or meiosis, making more me's, making more of myself, right? And instead of resulting in 2 daughter cells like the mitotic divisions, meiosis results in 4 daughter cells, and this is because each of these have half of the amount of chromosomes as any other body cells do, right? Instead of having that normal 46, they have 23 chromosomes. That's because they're going to join with the ovum, which has 23 chromosomes, and together they're going to make 1 cell. So they're each a half at this point. So these spermatocytes divide by meiosis and create 4 daughter cells, 4 half cells, if you will, to make more me's, called spermatids. And these spermatids are what are going to develop into spermatozoa, or what we refer to as sperm. As I mentioned previously, those primary spermatocytes are going to undergo mitosis, which is going to lead to those spermatids, which develop into spermatozoa, and this is happening in specialized cells called Sertoli cells. Sertoli cells. And we're going to end up with 4 spermatids. And interestingly, spermatozoa translates to seed animal, or the male reproductive cell. It kind of looks like a little animal, right? And then some terminology to familiarize ourselves with. The first one is ejaculation, and that's defined as forceful ejection of fluid containing sperm. And then the anatomy of the sperm is also something we need to be familiar with. So if you look at this picture here, there's the head of the sperm, and the head of the sperm is what is going to contain that genetic material. And at the very tip or very nose of the head of the sperm, we have something called the acrosome. And the acrosome is enzyme-rich area that allows the sperm to penetrate the egg when it does indeed find its way there. And then lastly, it's going to be loaded with mitochondria that is going to help it propel itself through the treacherous journey through the vagina, through the cervix, into the uterus, and oftentimes up into the fallopian tube to find the egg. And that tail we refer to as a flagellum. And the flagellum is the whipping tail that is going to provide the motion for the sperm. Here is an image of that spermatogenesis that we've already talked about. You can see that initially the spermatogonia undergo this mitotic division where they're making exact replicas of themselves, and then eventually they're going to develop into those primary spermatocytes and then into those four spermatids via meiosis, and then this is an enlarged view. This yellow area is the wall of the seminiferous tubule, and you can see that this process starts way on the periphery, and then as it continues, we get closer and closer to the lumen of that seminiferous tubule until the developed sperm enter the tubule and then make their way to the epididymis. Those interstitial cells that produce testosterone are referred to as Leydig cells, and the Leydig cells are stimulated by the gonadotropin luteinizing hormone. So what does testosterone do for the male exactly? Well, first of all, it helps to masculinize the male. For instance, when a young boy's voice changes, it's testosterone that brings that about. It also promotes and maintains the development of the male accessory reproductive organs like the prostate gland, the seminiferous tubules, and so on and so forth. And then lastly, it has a stimulating effect on protein anabolism. Remember, anabolism is the building up, making something bigger from smaller components. So it's going to be responsible for the greater than average muscular development and strength of the male. Here is just another look at the cross-section of the testicular tissue, these round areas being the seminiferous tubules, and in between spaces, the interstitial spaces, we see those little Leydig cells in there. Once the sperm enter the seminiferous tubules, they begin their long journey to the epididymis. And the epididymis is a single coiled tube about 6 meters or 6 yardsticks in length, and it lies at the top and posteriorly to the testes in the scrotum. And the sperm are going to mature and develop the capacity for motility as they pass through the epididymis. The epididymis is also going to be secreting nutrients for the developing sperm, and then they also absorb excessive fluid that is there as the sperm are maturing. Now, a condition that can occur with the epididymis is called epididymitis, and that is typically associated with sexually transmitted diseases and can present itself with pain and swelling and redness and an increased white blood cell count. And typically that would be treated with some form of antibiotic therapy. So we said previously that the epididymis receives the sperm from the seminiferous tubules, and there the sperm are going to lie in wait until their chance to participate in this wonderful thing called reproduction. Now the vas deferens is the tube that transports sperm from the epididymis into the ejaculatory duct so that it can be excreted through the urethra. The vas deferens, they make up a component of the spermatic cord. And in the spermatic cord, along with the vas deferens, are the vasculature and the nerves that supply the testicles. Okay, and so I highlighted in yellow here the vas deferens, also called the ductus deferens. And if you've ever heard of a vasectomy, this is the structure that we're ligating and dividing to render the male sterile so that they can't have children anymore. So you can see that this yellow tube that I highlighted, the vas deferens, is going to meet up with something called the seminal vesicle, and I highlighted that in blue, and the two are going to come together at the ejaculatory duct. Now it's important to note that the ejaculatory duct passes through the prostate gland and permits sperm to empty into the urethra, which eventually passes through the penis and opens to the exterior at the external urinary meatus. Now, if there is an enlargement of the prostate, it is going to inhibit this process. Again, like I said, if we have an enlarged prostate, that is going to start pushing back on that pathway through the prostate, and so that can inhibit the flow of urine as well as inhibit the flow of sperm and semen. Now, semen or seminal fluid is a combination of components from various accessory or supportive sex glands, and the average amount per ejaculation is approximately 3 to 5 milliliters. When you compare that to a whale, it sounds like nothing, which is 20 liters per ejaculation. Now, back to the human male, each milliliter of semen contains about 20 million to 100 million sperm. And the seminal vesicles, like I said, the vas deferens joins or enters at the seminal vesicles, and that is two pouch-like glands, and they produce about 60% of the seminal fluid volume, and they secrete kind of a yellowish, thick, sugar-rich substance that is going to provide the energy that the sperm need to make their journey successful. Now, the prostate is shaped like a donut, and it sits right below the bladder. And there is a part of the urethra, as I said before, that passes through the prostate gland. Now, the prostate is this very lobulated gland that secretes about 30% of the seminal fluid volume, and it activates the sperm and is needed for ongoing sperm motility. The male has two additional glands called the Cowper's glands or bulbourethral glands, and they're about the size of a pea, and they secrete a mucus-like fluid that makes up about 5% of the seminal fluid volume, and its job is to lubricate the portion of the urethra that the sperm is going to pass through. You might have heard this referred to as pre-ejaculatory fluid. The penis and the scrotum are referred to as the male genitalia. The penis has 3 columns of erectile tissue, 2 in the back and 1 that surrounds the urethra. And those 2 dorsal columns are referred to as corpora cavernosa, and the column that surrounds the urethra is referred to as the corpus spongiosum. These tissues are significant because they're very sponge-like tissue that becomes engorged with blood during an erection. The glans penis is the most distal portion of the penis, referred to as the prepuce, or the head of the penis, and it is covered with foreskin. Now, shortly after birth, this can be excised, and we refer to that as a circumcision. So my question to you is, can you fracture a penis? I'll leave you with that thought. The scrotum is a skin-covered pouch suspended from the groin, and like I said, there are 2 muscles that are responsible for regulating the temperature of the sperm, and that is the dartos and the cremaster muscle. And the scrotum is divided by a septum into 2 sacs, and each sac houses a testicle. Okay, they also have an epididymis, which sits at the top and posteriorly on the testicle, and there's also a part of the vas deferens. Now, those vas deferens make up the beginning of the spermatic cord, and something significant to remember is that spermatic cord is going to pass through the inguinal ring and into the abdomen, and this is a natural weakening in the abdominal wall of the male. And this is why males are more susceptible to inguinal hernias than females are. There are 3 common causes for infertility in the male. And 3 most common ones are oligospermia, cryptorchidism, and testicular cancer. Oligospermia is characterized by a low production of sperm, and this could be a result of an infection, fever, radiation, malnutrition, and high temperature in the testes. Some studies have been conducted that show that if males spend a lot of time in the hot tub, or if they wear briefs instead of boxers, this could also contribute to oligospermia. Cryptorchidism is failure of testes to descend into the scrotum, and if we have a male that is born with cryptorchidism, we typically wait about 12 months to see if the testicles will descend on their own. Some reasons that they may not descend could be due to a hormonal imbalance, physical deficiency, or obstruction. But because the internal temperature of the male is a lot higher than the sperm then this could also lead to infertility and or permanent sterility. So again, treatment would be to either perform surgery or perhaps they might try a less invasive method of injecting the individual with testosterone to hopefully facilitate the testes to descend into the scrotum. And then lastly, testicular cancer. Malignancies of the testes are the most common among men between the years of 15 and 30 years old. And there's a lot of talk out there about how important that how important it is that women do self-breast exams, but it's equally important that males are doing their self-exams as well, because early detection is the key to survival. So, if you feel something abnormal, then, it's important to get that checked out right away, because if it's allowed to proliferate, it could metastasize, or we might not be able to care for it as we would be able to if it's detected early. So treatment for testicular cancer, radiation, chemo, of course, surgical removal of the testicle. If we are performing a surgical removal of the testicle, we typically remove it from an inguinal incision. You you think it would make sense that we would remove it from the scrotum, that would be easier and less invasive. Yes, it is. However, we run the risk of transferring cells from the malignant testicle to the non-malignant testicle, so through a scrotal approach. So an inguinal approach greatly reduces that chance. Moving on to disorders of the prostate, something that I've mentioned before is benign prostatic hypertrophy, or BPH. You might see it written or hear it said, which is enlargement of the prostate. It's common in older males. However, it is not malignant, right? It's not cancerous, it's benign, but the tissue of the prostate proliferates and gets larger, and that could inhibit urination. It could also inhibit, the passage of semen and sperm through that pathway as well. Prostatectomy is something that we might perform for BPH. A lot of times we do something for BPH called a transurethral resection of the prostate, or a TURP. However, if there is a malignancy, or the TURP wasn't successful, or the patient's not a good candidate, then we may have to remove the prostate in its entirety, which is a lot more invasive procedure. There are several different approaches, and we are using the Da Vinci robot to do that now, so it is can be a less invasive procedure for the patient, so that's really good. Prostate cancer, the malignancy of the prostate tissue is a leading cause of cancer deaths in men over the age of 50. Again, this is why it's extremely important to get your annual exams, so that if there is something going on, it can be detected early and then treated successfully. And then lastly, brachytherapy, which I think I've mentioned in class before. Brachytherapy translates to or brachy means short distance. So again, this entails inserting these very small radioactive seeds directly into the prostate. We do this under anesthesia, and typically there's a surgeon and an oncologist there, and they use this special device and these special needles called brachytherapy needles to position those seeds right in the areas where the cancer is, and so that they can directly treat that cancer. Here are some images to go with the words that I was talking about on the previous slide. So this first top left one, you see the brachytherapy procedure, and in the lithotomy position, we can go ahead and insert this device into the rectum, and then it has this kind of upper portion that will guide the brachytherapy needles to insert those seeds into the prostate gland. So that's brachytherapy. On the top right, you're seeing what is the transurethral resection of the prostate, or the TURP. So for benign prostatic hypertrophy, we can enter through the urethra and gain access to the prostate gland, which lives at the bottom of the bladder there. You can see the scope, and then they also attach something to the scope called a resectoscope, and the resectoscope uses a monopolar cautery, and it will allow them to take little bites or bits, carve out little bits from the prostate and open up that pathway, the TURP. And then this bottom one is just showing the Da Vinci robot being used for a prostatectomy. We're going to run through some terminology associated with disorders of the penis and scrotum, and then I have some images coming up on the next slide. So first and foremost, phimosis. Phimosis occurs when in a male that has not been circumcised and still has that foreskin, and sometimes that foreskin will get stuck behind the glands of the penis, and the male won't be able to advance it forward over the glands, so it gets stuck there and then eventually causes inflammation, can actually begin to act like a tourniquet. Paraphimosis is when the foreskin cannot be replaced to the usual position after it's been retracted. So phimosis is the tight foreskin that can't be retracted over the glands, and then paraphimosis is it can't be replaced. Erectile dysfunction is failure to achieve erection of the penis. Hydrocele is an accumulation of fluid in the scrotum. An inguinal hernia is the protrusion of abdominal pelvic organs, possibly into the scrotum, through that inguinal ring. Remember I said it's a natural weakness in the abdominal wall for the male. And so there's an increased chance of hernia there in that area. Hypospadias refers to the urethra opening on the underside of the glands or the shaft of the penis, and that underside is depicted by when the penis is flaccid, the underneath is going to be touching the body, the closest to the body, and then epispadias is an opening of the urethral meatus on the top of the glands or the shaft of the penis. And these are typically genetic, congenital abnormalities. And then lastly, testicular torsion, which is when a testicle becomes twisted within the scrotum. So let me walk you through the images here. Top left, we have inguinal hernia in this little guy, and you can see that the scrotum looks very enlarged, and that's because content from the abdomen, whether it's omentum or intestines, slips through that inguinal ring down along the spermatic cord and can eventually track down into the scrotum. Below that, we have hydrocele. Like I said, a hydrocele is where fluid collects inside the scrotum. And then below that, we have something called chordee. And again, chordee is a congenital defect where there's a tight band on one side of the penis that causes it to pull to one side. On the right side of the screen, you see phimosis and paraphimosis. And then, and to treat that, we would do a circumcision. And then below that, we see the hypospadias, and you can see that the opening to the urethral meatus is on the underside, and then hypospadias would be the reverse. The opening would be on the top side. So that concludes our discussion about the male reproductive system. Now we're going to begin our discussion about the female reproductive system, and we're going to start in the same place by talking about the structural plan and those essential organs versus the accessory organs. So for the female, the essential organs are the ovaries. Okay, and the ovaries produce the sex cells, which we refer to as the ova. That's plural, ovum for one. The accessory organs of reproduction are all the rest. The ducts, including the oviducts or fallopian tubes, the uterus, the cervix, and the vagina, and then various sex glands, including the breasts and the external genitalia. Here is our image of the female reproductive organs, and here I'm highlighting in yellow the ovary. That is our essential organ. Everything else is considered accessory organs, except for the rectum is not a part of the female reproductive system, but it is on this image here. So we can see the uterus, and that neck of the uterus is called the cervix, which extends into the vaginal canal. Okay, and then shows a little bit of the external genitalia here. It also shows the bladder, which again is not a part of the female reproductive system, but it does give you an idea of where the uterus is in relation to the bladder. It sits in front and below the uterus. Similar to how the male has 2 testicles, the female has 2 ovaries. And the ovaries resemble 2 large shaped almonds that are approximately 3 grams each, and they're situated on each side of the uterus. So I pulled some images here so you can look at this top one, and it is a graphic image of the a computer graphic image of the ovary and the fallopian tube. You can see it there. That white thing is the ovary. And then on the bottom left, this is a close-up of what a real ovary would look like. And then on the bottom right, you're looking at the fundus, or the top of the uterus, and then you can see the tubes and also an ovary there, that white structure that's on the right side attached to the tube. So just to give you an idea of what it looks like in a real human. And so these ovaries are attached to ligaments in the pelvic cavity on each side of the uterus. The ovary is held in place by the ovarian ligament, and the ovary and the ovarian ligament lie within another ligament called the broad ligament. And if we were to look at the ovary microscopically, we would see these little follicles or little pockets. You know, we talked about it with the integumentary system, how our skin has follicles, and there are these little pathways where hair develops. And so this is a little area similar to that where an egg develops, or an oocyte develops into a mature sex cell. The female has about 400,000 primary follicles at puberty, and that is the maximum amount of potential ova that the female is going to have. So for those of you that stayed tuned to discover if size really does matter, it's interesting to note that the female sex cell is the biggest cell of all the cells in the human body, and the sperm cell is the smallest cell in all of the cells of the human body. Now, when we're talking about the female sex cell, we said that's called the ovum. The female is born with about 500,000 of these eggs, all right? And they are in these little follicles, and each of these follicles has an immature ovum called an oocyte. Now, by the time the female reaches puberty, that's been reduced to about 400,000 of these primary follicles. And these primary follicles, you can see the start of that right here. Let me highlight it for you. Here's the primary follicles, okay? And similar to how the spermatogenesis occurs, where the immature cells are on the periphery of the seminiferous tubules, similar thing is occurring here. So you can see how these primary follicles are a fair distance away from where they're actually going to exit the ovary. Okay, so by puberty, the female has about 400,000 primary follicles, and they're encased in a layer of cells called granulosa cells. And as this granulosa thickens, a hollow chamber is formed around the ovum called an antrum. Okay, and during the life of a female, approximately 350 to 500 follicles develop into mature follicles, and eventually they rupture out of the ovary of this follicle, and this process is called ovulation. Now the mature follicle that is at the end there, where you see ovulation occurring, is referred to as a Graafian follicle. Now after ovulation, this follicle is transformed into a hormone-releasing structure that we call the corpus luteum. Similar to spermatogenesis, oogenesis also includes two meiotic cell divisions. And you can see here that the oogonium, which is the immature female reproductive cell, divides, and that becomes the primary oocyte. That is a mitotic division, so that's mitosis. So then when we get to the first stage of meiosis, we have this dividing, and then there is an unequal division of the cytoplasm. So we get this really big cell, and then we get this little bitty one called a polar body. Now the big cell is what's going to go on to become the ovum, and that little cell called the polar body is going to eventually degenerate. And when fertilization occurs, that's when the final phase of meiotic cell division is completed and that last polar body is released. And this is called oogenesis. The second major function of the ovary is the secretion of sex hormones. And the two sex hormones are estrogen and progesterone. Now, estrogen is predominantly secreted by the granulosa cells that surround the developing oocyte. And once ovulation occurs, the corpus luteum is going to be responsible for secreting progesterone and also a little bit of estrogen. So what does estrogen do? Estrogen is responsible for the development and maintenance of the female's secondary sex characteristics. It also stimulates the growth of the lining of the uterus to prepare for implantation. It helps in the development and maturation of the female reproductive organs, also responsible for pubic hair and breast development. It also serves to provide the shapeliness of the female, and it also is responsible for initiating the first menstrual cycle. Now, progesterone, like I said, is going to be secreted from the corpus luteum following ovulation. And if everything goes well, the corpus luteum will continue to secrete progesterone for about 11 days after ovulation. This is going to stimulate the proliferation of the lining of the uterus, and it also works together with estrogen to initiate that menstrual cycle in the early onset of puberty. The reproductive ducts are also referred to as the uterine tubes, fallopian tubes, or oviducts. So they have a lot of different names for the same thing, but you can see in this top image here, the fallopian tubes are identified. So I'm trying to highlight them yellow, but you really can't see that. What if I use red? Okay, so here we can see the fallopian tubes. There's one on the other side as well, right here, and the ovaries are connected to those. Now, the fallopian tubes are not attached to the ovary at their terminal end. So if you look at this bottom picture, can see this interstitium is where the tube enters the uterus. This area is called the cornu, and then there's some segments of the tube, the isthmus, the ampulla, and the fundibulum, and then it terminates at these little fringes, right? And these little fringes are called fimbriae, and their job is to act like little sweepers and sweep up the ovum. So the ovum is going to be expelled from the ovary here, and then it's going to be roaming about in the abdominal cavity, right? It's going to get swept up by the fallopian tube. Okay, now fallopian tubes are about 4 inches or 10 centimeters in length, and inside them, if we were to peer inside, we would see all these little tiny cilia, and the cilia are going to serve a purpose and continue to sweep that ovum and keep it moving towards the uterus. All right, an important thing to note is that the mucosal lining of the tubes is directly continuous with the lining of the pelvic cavity on one end and the lining of the uterus and the vagina on the other. This is significant because infections in the vagina or the uterus can pass into the abdominal cavity, and this can become a life-threatening situation. So here we're looking at the uterus, and the uterus is suspended in the abdominal pelvic cavity by several different ligaments. And as I mentioned before, the ovary is suspended by the ovarian ligament, but that also lies within the broad ligament here. And there's these pairs of ligaments are on either side, and the broad ligaments kind of like these angel wings that spread out. You can see the ovaries and the tube lie within that, and then identifying the ovarian ligament there. And then as we move downward, this area here of the uterus is referred to as the body. All right, I don't know if I can write body or not. We're going to put B for body. All right, and then this part up here is called the fundus. I'm going to put an F for fundus. Okay, and then as we continue moving southward, the neck is the cervix. Okay. And there's 2 openings to the cervix. There's an internal opening and this external opening. Openings are referred to as os, O-S, so there is an internal os and an external os of the cervix. And that cervix extends down into the vaginal canal. This is vagina here. Okay, and some other interesting structures to point out. This uterosacral ligament down here. There is also a round ligament. I think it's probably right about here that comes out on each side, the round ligament. And all of these serve to attach the uterus to the abdominal wall. And then lastly, we've talked about the urinary system, and I mentioned how when we are performing a hysterectomy that the ureters are right there up close and personal, and so you can see how they run right behind the uterus, and so it's important that we always identify those. Now, as far as some additional terminology that I forgot to mention previously is if we were to remove an ovary, would be called an oophorectomy. If we were to remove a tube, would be called a salpingectomy or salpingectomy. And so sometimes we remove both, so that would be a salpingo-oophorectomy. And if we were to remove the uterus, that would be called a hysterectomy. There's a couple different ways we do it. We can do a total abdominal hysterectomy, which would be removing just the uterus. Or if we do a TAH with BSO, that means we're taking the uterus, the ovaries, and the tubes. That is a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Okay, now the wall of the uterus is very muscular, and that thick muscular wall is referred to as the myometrium. Now the uterus is about the size of a pear, however it grows to 500 times its size to accommodate the developing fetus inside. Now, something that is a condition that can occur with the uterus is called endometriosis. The inner layer of the uterus is referred to as the endometrium, and because of that continuous lining, mucosal lining, cells of the endometrium can sometimes work their way out into the abdomen, and they implant themselves on the outside of the uterus, the tubes, the ovaries, and this is a painful situation called endometriosis. The vagina is a muscular tube that is about 4 inches long, and it's lined with mucous membrane. It is located between the urinary bladder and the rectum in the pelvis, and it receives the penis during sexual intercourse and is the birth canal for normal delivery of a baby at the termination of the pregnancy. There are 2 pairs of vestibular glands. The greater vestibular glands are referred to as the Bartholin's glands, and then the lesser vestibular glands are referred to as the Skene's glands. And the Skene's glands are likened to the male prostate, and so they're referred to as the female prostate. And so the Skene's glands, I don't think are shown in this image, no, but we do see the Bartholin glands and the ducts, and you can see that they're situated on either side of the vaginal opening in the vaginal canal, and their job is to provide lubrication during sexual intercourse. However, they can be a problem if they become infected. They can get enlarged, and on the bottom I have an image of that. This is called a Bartholin gland cyst, and we can take care of this surgically. We would do something called marsupialization. If you remember that a marsupial is an animal that has a pouch, we're basically going to marsupialize this cyst by making an incision in the cyst, cleaning out whatever is in there, and then stitching it open so that it can heal. So we refer to that as marsupialization. The breast lies anterior to the pectoral muscle, and it is composed of lymphatic vessels, milk-secreting cells, blood vessels, nerves, fatty tissue, and lactiferous ducts. Now, these milk-secreting cells are arranged in grape-like clusters that we refer to as alveoli. You may have heard that before when we talked about alveoli that are in the lungs. Now, the lactiferous ducts are responsible for draining the alveoli, and they converge towards the nipple in some small openings. And then there is the lymphatic drainage that is also drained into the axilla. And as we said before, this drainage of lymphatic fluid is what is responsible for the process of metastasis. Now, the areola refers to as the colored surface of the nipple, and on the surface of the areola, there are these little tiny bumps, and those little bumps serve to help the infant latch on to the breast when it is time for breastfeeding. So the external genitalia of the female consists of several structures, and collectively these structures are referred to as the vulva. So these structures include the mons pubis, the clitoris, the external urinary meatus, the labia minora and majora, the hymen, openings of those vestibular glands we talked about before, the Bartholin's glands and the Skene's glands, the opening to the vagina. And so the mons pubis is a fatty pad that covers the symphysis pubis, and in this picture you can see that it is at the top here. Let me sketch it out for you. So mons pubis is here, and the extending downward from the mons pubis are two folds, and there's two on each side. The outer folds called the labia majora, and these are the ones that are covered with pubic hair, and then the labia minora are the inside folds, the innermost folds, and then that space between the labia minora, that opening, is referred to as the vestibule. Okay, now the perineum is a term that we use to describe the area between the vaginal opening and the anus. And if there was a situation where mom is in labor and she's at risk of tearing the vaginal opening, then the surgeon or the obstetrician would go ahead and perform something called an episiotomy. And this is a cut in that vaginal opening to allow for an easier passage of the baby. Okay, so that is an overview of the external genitalia. Now, the menstrual cycle consists of many different changes in the uterus, the ovaries, and the breast, and in the hypothalamus and anterior pituitary gland secretion of hormones. So in the majority of women, these changes occur with almost precise regularity throughout their reproductive years. And the typical menstrual cycle is about 28 days, and day 1 starts with menstruation or menses, and that's going to last anywhere from 1 to 5 days according to the book. Here you can see this cycle extends it into day 7. So menses is going to be the start of the cycle, and then after menses, the next few days are going to be referred to as the proliferative phase, and this is where the uterine lining is going to be repairing itself. On day 14-ish, ovulation is going to occur. Moving forward from ovulation, we have the secretory phase. Remember, this is when the corpus luteum is excreting hormones, and it's helping to prepare that uterine lining for pregnancy, right? Because we said the goal of every living thing is to reproduce, and it's no different with humans. So that secretory phase is going to serve to prepare the uterus for implantation. And then if implantation does not occur, we're back to day 1 with menstruation. Menstrual cramping is also referred to as dysmenorrhea, and there's 2 different types of dysmenorrhea, primary and secondary. Primary dysmenorrhea is what we typically refer to as cramps. And the reason these cramps happen is because, remember way back when we talked about prostaglandins, and we said that prostaglandins do some jobs. They're secreted by the tissues, but they can't really do a job far away, right? So prostaglandins are what are responsible for causing this inflammatory response and this cramping. The good news is that it typically only lasts a few hours to a few days and can be treated with over-the-counter anti-inflammatory drugs like ibuprofen or naproxen. Secondary dysmenorrhea, however, is typically related to some sort of gynecological problem. And so what they would do is treat that underlying disorder. Now, amenorrhea means the absence of normal menstruation, and there's 2 types, again, primary and secondary. Primary is the failure of the cycle to begin, and it could be caused by a variety of factors, first and foremost being hormone imbalances, could be caused by genetic disorders or other sort of neuro disorders as well. Could also be due to structural deformities of the reproductive organs. Now, secondary amenorrhea occurs when a woman who has previously menstruated doesn't have a cycle every month. Maybe it's only every 2 to 4 times a year. This could indicate menopause or disease of the reproductive organs of some sort. Now, dysfunctional Uterine bleeding is irregular or excessive bleeding, and that can also result from a hormonal imbalance or some sort of pathology. It can be treated with different types of drugs. We can also do something surgically called an endometrial ablation, where we burn the inner lining, cauterize the inner lining of the uterus and cause it to slough off, which a lot of times helps. Or we can perform a hysterectomy as the last resort. And then premenopausal syndrome, PMS, it is a thing, all right? It's a condition that involves a collection of symptoms that regularly occur in some women during the secretory phase of the reproductive cycle. And so some symptoms might include irritability, fatigue, nervousness, depression, and other problems that are often distressing enough to affect personal relationships. There's a lot of hormone fluctuation during the secretory phase, and because of that, these symptoms can be brought on and can be exacerbated by that. Infections and inflammation can be caused by different types of pathogens or that lead to infections in the reproductive system. And so pelvic inflammatory disease is one of those that affects about 800,000 women each year in the United States and can be caused from the bacteria that causes gonorrhea and or chlamydia. And so the seriousness of this, like we said before, infections can leave the reproductive tract and enter the abdominopelvic cavity, okay? And that leads to pelvic inflammatory disease. And in surgery, sometimes we tease and say PID stands for pus in der. There's pus in der, all right? Because you're gonna look in the abdomen and you're gonna see fluid in there. It could be green fluid, it could be pussy fluid, but pelvic inflammatory disease, you're going to find some sort of fluid in the abdominal cavity. And then vaginitis is another type of inflammation that can occur or infection that can occur due to something going on with the vaginal lining. Again, it's most often a result of some form of sexually transmitted disease or possibly from a yeast infection. Yeast infections are predominantly caused by Candida, and sometimes as females, taking antibiotics can change the flora of the vaginal canal. And so there are certain normal bacteria that live there that are good. And so when we take antibiotics, it could kill off some of that good natural bacteria, which could lead to the proliferation of Candida and lead to some sort of yeast infection. A fibroid or a myoma is a benign tumor that can occur in that muscular layer of the uterus. And so this top image, you can see these tumors that are in that myometrium, and these are referred to as fibroids. And then the bottom picture, this is what they really look like. And we're looking into the abdomen, and you can see all of these different tumors. There's a uterus down there somewhere, okay? Typically, they do not resect myomas or fibroids because the uterus is very vascular and there's a good chance that the patient could bleed to death. So probably the way that we're going to fix this is with a hysterectomy. Something else that can happen is cysts can develop on the uterus. It's not an uncommon thing. Some people might not even know that they have them, but sometimes they can get very large and be very painful, and sometimes surgery is required because of that, especially if they have several of them and they're reoccurring. Something else that can occur is polycystic ovary syndrome, PCOS. And this is a condition that affects about 10% of women that are in that reproductive age. And what happens is that matured follicle, that Graafian follicle, fails to rupture completely. And so what happens is we get these fluid-filled cysts that are covering the ovary, and this can lead to infertility. And so in this situation, at some point, the patient might need to have an oophorectomy because of that. So I added these images. This bottom one is kind of more for shock and awe than anything else. This is a gigantic ovarian cyst, and I actually helped remove an ovarian cyst that was about this size at one point in my career. And so these can become extremely large. It's not common, but the individual where we removed this very large ovarian cyst, she said, I just thought I was gaining weight. I didn't know what was happening. And finally, it was causing her enough discomfort. She went in and they found she had this gigantic ovarian cyst. So this fluid-filled sac, right? And then endometriosis, I had mentioned before, this top image is related to endometriosis, and the cells from the endometrium, the inner lining of the uterus, can work their way out the fallopian tube and implant themselves in the abdominal cavity. And this is very uncomfortable. There's really not a cure for this. Sometimes the surgeon will go in with some sort of cautery and cauterize the little implants that might help the patient, so they don't have to have a hysterectomy or something. There are various types of cancers associated with the female reproductive system. About 1 in 8 women eventually get breast cancer in their lifetime, which is often a form of adenocarcinoma. The treatment depends on how severe the cancer is, but one possible treatment is a radical mastectomy, and a radical mastectomy includes removing the breast and the muscles that are underneath the breast all the way down to the chest wall. And then that would also include doing a sentinel node biopsy, and if it was dirty, then a axillary node dissection as well. Now, there are also modified radical mastectomies, there's segmentectomies, there's lumpectomies, various different things depending on what is best for the patient or what the physician and the patient decide is best course of action. Ovarian cancer can be a result of metastasis of breast cancer, or it can arise independently. Ovarian cancer affects about 1 in 70 women in America. Again, typically adenocarcinoma. And the treatment would be surgical removal of the ovaries combined with radiation and chemotherapy. Uterine cancer. Uterine cancer generally occurs in postmenopausal women, and this could be because they start taking estrogen. Okay, so once the female's body goes through menopause, she's no longer producing estrogen, and estrogen is needed to maintain strong bones, and so sometimes they will prescribe estrogen therapy, and this can lead to cancers in the female body. Cervical cancer is associated with women between the ages of 30 and 50, and this is why it is so important for women to get their annual pap smears. Now, if you've had several normal pap smears in a row, the physician might suggest that you can wait 3 years before you get your next one. However, if there is a history in your family or you just don't feel comfortable with that, it is really important that you communicate that to your physician and get those annual checks, because again, early detection is the key to saving a life, okay? As with the male reproductive system and infertility, there are various disorders that can interrupt female fertility as well. And that's some of the things that we've already talked about, like infections, tumors, hormonal imbalances, genetic abnormalities. They run the gamut, right? A bunch of other factors. And then just important to note that for sexual reproduction to work, it requires 2 normal functioning individuals, right? The male and the female, or it's going to require healthy sex cells. So we're going to close this lecture on the reproductive system by having a brief discussion about sexually transmitted diseases. Sexually transmitted diseases used to be referred to as venereal diseases. Another term you may have heard is sexually transmitted infection. There is a difference, however. Sexually transmitted infection means an individual is infected with one of these pathogens. However, they might not have symptoms yet. So once they do have symptoms, then that is referred to as a sexually transmitted disease. Now, just because sexually is in the term doesn't mean that that's the only way that they can be contracted. Yes, they can all be contracted by sexual contact, but in the instance of something like HIV, HIV can also be spread by transfusion of infected blood, using contaminated medical instruments such as intravenous needles and syringes. And there are some of the most common ones listed here. There are also common ones listed in your textbook on page 640 with their definitions. All right, so that concludes our discussion regarding the reproductive systems. I know it's a lot of material to take in. I hope that you found it helpful. Thank you for listening.